Thank you so much for coming. We're really excited to have you here. So whenever you're ready, you can just get started. Thank you.
Awesome, thanks. You have can I share or?
Yes, I am pretty sure. Yes, you can.
Awesome.
Okay.
Hey, so for the are most of you guys in high school, college? What's kind of the?
We're a mix of high school and college students.
Okay, cool. Awesome. Let me just share here. All right, so I'll just kind of give a brief overview of kind of what I do, and then how I chose it, and kind of a day in the life kind of thing. And then if you guys have any questions, just let me know. And don't be shy. You guys can ask whatever you want, even if it has nothing to do with spine or orthopedics or medicine. Just feel free to ask. So again, sorry I'm late. Thanks guys for putting this together and for hanging out with me on a Sunday. So my name is Andrew Chung. I'm a fellowship trained spine surgeon, specifically orthopedics. So I kind of had an interesting path to medicine. Really kind of didn't get my act together until mid undergrad. Ended up in a chiropractic school, and it was there that I kind of decided to get together. And hey, you guys mind muting yourselves for now? Hey, thanks. It was there that I kind of got my act together, and just kind of given the background of coming from chiropractic, decided to go the osteopathic route and applied to the Philadelphia College of Osteopathic Medicine, and was fortunate enough to get in. So that's where I did medical school, and I actually went to the Georgia branch, just because I had some family out there. And then did my orthopedic surgery residency at the Mayo Clinic in Arizona. I don't talk too much about what orthopedic surgery is, just because my specific training is, or my specific kind of focus now is spine. But in orthopedics, basically, you learn how to treat everything from the neck down that's related to the musculoskeletal system. So whether surgical or non-surgical, we learn to treat that. So that includes like broken bones. That includes, old lady comes in with a bad hip, bad knee, you learn how to replace that. Bad shoulder, replace that. Sports injuries. So any of you that follow sports or play sports, you guys may have heard of like ACL injuries or tears, meniscus injuries. So we learn how to treat all that in orthopedics. Any tumors of the musculoskeletal system, so bone tumors, muscle tumors, you learn how to either remove them or kind of address them. Pediatric ortho is cool, and very meaningful work actually. You basically do all of orthopedics for kids, but that also includes a lot of kind of limb deformity kind of correction, and from a spine standpoint, like scoliosis correction. So basically, you've got these kids that not oftentimes, but may have some syndromes that create, deformed limbs, or maybe one limb is shorter than the other. Maybe it's crooked, and we can kind of fix those things to a certain degree. So pediatric ortho is pretty cool from that standpoint. Hand surgery is also part of orthopedics. That was actually my second choice, just because the hands are so obviously vital, right, to everything that we do. And being able to restore function to hands is such a meaningful thing to be able to do for people. And so I really enjoyed hand surgery. And then foot and ankle surgery is another discipline of orthopedics. So we really kind of do it all in residency, and it's, I don't know. I mean, I loved it. I think it's a great specialty for any of you who are interested in surgery in the musculoskeletal system. and really meaningfully kind of impacting people's lives. I think being able to restore function for people is just a huge kind of gift that we're able to kind of give them. And then, I think nowadays, I think we think a little bit more about lifestyle. And as far as surgical specialties go, orthopedics typically allows you to have a better lifestyle once you get done. The orthopedic surgery residency, any surgical residency is going to be tough during the 5 years or however long that residency is. But once you're done, really kind of the world is, free to kind of navigate however you choose in terms of your lifestyle. So oftentimes orthopedic guys and gals have a pretty good lifestyle once they get out, and it's, it pays well. So because of that, it tends to be one of the more competitive specialties to match into, and it's becoming increasingly so, when you look at the quality of applicants that are going into orthopedic surgery. So that's kind of an overview of orthopedics, just because I don't talk about it beyond this. But so that was my background, and then I specifically decided to focus on spine surgery. And so I did my fellowship at Keck USC Hospital, University of Southern California, and I trained with both orthopedic and neurosurgical spine surgeons there. And then currently, just because I just can't get enough of learning, I'm doing an extra 6 months with a pretty famous guy here at Cedars-Sinai in LA, and some of the other guys at Cedars-Sinai in some advanced techniques. And then I'll be moving to Phoenix, Scottsdale to join one of the spine practices there in about 2 months here. So beyond that, I'm a normal guy. I got a family, got 2 awesome little girls, and I'm just a normal human being. So as far as how to become a spine surgeon, you've obviously kind of gotten a taste of one of the routes to spine surgery, really the better route to spine surgery, which is orthopedics, and then a year of spine fellowship. Again, orthopedic surgery residency is somewhere between 5 and 6 years. And then mine was 5. Sometimes some residencies will incorporate like a research year or something like that. And so that's why some residencies may be 6 years. That's really a choice that, ultimately is yours. And so totally you're looking at 6, 7 years in addition to, medical school and undergrad, or 6 or 7 years of undergrad if you're me. And then on the flip side, you can go the neurosurgical route. And so neurosurgery, obviously they deal with the brain, but they also deal with the spine. And their residency is about 7, 8 years. And then in most cases, because they're dealing with just the brain and the spine, they get enough spine training throughout their 7, 8 years of residency to come out and practice independently and do spine surgery. Whereas on the orthopedic side, we need that additional year to really get the experience in most cases to perform spine surgery, and it's just required from our standpoint. That being said, nowadays more and more academic centers, hospitals are requiring even the neurosurgeons to be fellowship trained, and so they'll end up doing an additional spine fellowship. So you're looking at potentially a very long road. And then, when you look at the residency itself, they tend to be a little bit more grueling of residencies than orthopedics. And then lifestyle afterwards, because oftentimes these guys are taking cranial call or brain call. Their lifestyle after, once they're done with residency, is maybe a little bit, or in a lot of cases, a lot bit more tough than what my schedule would be like. So things to kind of think about. As far as scope of practice, like once you become a spine surgeon, whether you go the neurosurgical route or the orthopedic route, is there a difference? And nowadays, most would say that there is not. So when you go to the major spine societies, and you kind of look at who's who in spine, right? Like who's the LeBron James of spine surgery, right? Or the Venus Williams of spine surgery, right? It's going to be a mix. In fact, traditionally, more of the academic spine guys were orthopedic guys, And that has over the last 10 years or so started to change a little bit. So bottom line is really there's no difference at this point. Really, there's even been talks of creating a spine surgery residency just to kind of clear the confusion here. So whether neurosurgical or orthopedics, whatever your kind of choice and whatever fits with your personality and your kind of your drive, that if you end up a spine surgeon, you're a spine surgeon. Now, there are some kind of little bit of differences just based off of the history of kind of how spine surgery evolved in each one of these disciplines. But for instance, like the neurosurgery guys, they'll predominantly kind of do the intra like dural type tumors, so spinal cord tumors and stuff like that. Orthopedic guys, we tend to stay away from that just because it's not something that we do a lot of. I did some in fellowship. I don't really want to do any of it, but that's kind of a difference in training. As far as orthopedics, traditionally we've tended to do more of the deformity surgery. So little kids with S-shaped spines or crooked spines, we fix those. And then in adults, kind of the same thing. So on a pediatric side, orthopedics still kind of pretty much dominates that. On the adult side, adult deformities really, again, the two disciplines have become one in that regard. And so again, bottom line, we're kind of splitting hairs here. At the end of the day, if you're a spine surgeon, you're a spine surgeon. I would say from what I think that orthopedics brings to the table that maybe you don't get in a neurosurgical residency is understanding the extremities like we do. And as you'll see, as you guys go through medical school and stuff, as you'll see, there's a lot of musculoskeletal kind of ailments or diseases that can mimic referred pain from the neck. So what I mean by that is if you have a pinched nerve in the neck or the low back, each one of those nerves in the neck or the low back controls our ability to feel or move a certain part of our arm or a leg. And so, for instance, if you have a pinched nerve in the neck, and it's, let's say, like we call the C6 dermatome that's being affected, you may have pain kind of in this part of the hand here, right? Kind of thumb, outer forearm. And when you think about that, there are a lot of musculoskeletal issues that can cause that type of pain. So you can have a pinched nerve at the wrist called the carpal tunnel that can cause pain and numbness in the thumb region and kind of inside of the hand. You can have arthritis in the thumb, which is very common right here, which can present with weakness even in pinch and pain right there. And so that can be confused with a pinched nerve in the neck. You can get various tendinitis in the elbow, like tennis elbow, which can be confused with that. And there's various nerve entrapments that can occur in the arm that can also kind of muddy the waters, if you will, when you're trying to, figure out what's causing somebody's pain. And so that's all within the orthopedic territory. We learn all of that. We learn how to treat that surgically. We know how to diagnose that. So I think from a diagnostic standpoint, I think we tend to be a little bit better in that regard. Same thing with the legs. We deal with hip, knee, thigh, ankle, foot issues, and all those things can mimic pinched nerves in the back. And you have to be very careful, right, when you're treating patients that you're doing the right thing for them. And so you don't want to be the person to misdiagnose something for somebody. So I think that's where we kind of shine, is really in the diagnostic portion of things. But at the end of the day, again, there's no huge difference between the two nowadays. So I hope that's helped. To that point, again, during fellowship, I trained with both types of surgeons, traditionally orthopedic guys, traditionally neurosurgical guys, and there are very excellent surgeons on both ends. And it's not that like if you're a neurosurgeon, you can't learn the physical exam. It's just that I think that you're prepared a little bit better, and vice versa. So what do we do as spine surgeons? We deal with both the operative and non-operative management of spine conditions, right? Spine, you deal with everything in the spine. So arthritis in the neck, back, probably the more common things that we deal with. Disc herniations. What that means is kind of in between each one of these building blocks here in the spine, you've got what's called a disc. It's like a cushion. And that cushion can actually, it's like a jelly donut. And on the inside, it's got this kind of gelatinous material. And sometimes that gelatinous material can actually kind of pop out the back and pinch on a nerve to cause pain. And so we deal with that type of stuff. Spinal deformities, you kind of see an example of that here. This is what we call a AP, anterior posterior, anterior meaning front, posterior meaning back. So you're looking front and back at this patient, anterior posterior x-ray. And you can see that this patient's got like an S-shaped curve to his or probably her spine, right? She's got some earrings on. That's not normal, if you guys are wondering. It should be more straight. And so you can see here that that's been corrected when you look to the x-rays on the right with rods and screws. And so that's what a spinal deformity correction looks like. We deal with trauma of the spine. So if somebody breaks their spine or has some sort of injury to their spine, we deal with that. And then tumors of the spine, again, we can deal with. They're rare, but they do happen, and we learn how to deal with them. The things that I love about spine surgery are, one, the anatomy is so awesome. You look at you get a model of the spine and you look at it and it just looks so simple when you actually look at it, when you just look at a model. But what it really comes down to is every single millimeter within that spine counts. And so you have to be very precise in your knowledge of the anatomy. And, the reason why that's important is because when you're actually operating around the spine, if your knowledge of the anatomy is not that great, and you're a millimeter off and kind of where your tools are, you can seriously injure somebody. So in the neck, millimeter, 2 millimeters off of where you're supposed to be, or you're working around the spinal cord, you dive a little bit too deep, a millimeter, 2 millimeters, you can literally paralyze a patient, and that's not a good day. And so really, you're dealing with some high stakes anatomy, some very complex anatomy. And to me, that's very fascinating. And the fact that, somebody's actually letting us work around that type of anatomy on them, I think is a huge privilege. And I don't know, it just gets me excited, keeps me coming back for more. And most importantly, it's something that I feel that will keep me interested, for the rest of my life. Because every day you kind of have to bring your A game, right? You can't, it's not like driving to work. You can kind of turn your mind off and, somehow you end up at work, right? You can't do that with spine surgery. You really have to be focused. You really have to bring your A game every single time. Otherwise, you can seriously injure somebody because the anatomy is so crucial. I think when you talk to most surgeons, they don't like clinic, right? I mean, that's why you go into surgery. So you want to be in the OR and you want to be operating. But for me, if I'm going to be in clinic, I want it to be interesting, right? Like I want to be, kind of mentally stimulated. And I kind of talked to that, when I talked about how I think orthopedics has a little bit of an advantage when it comes to the exam and diagnosing of spinal issues, because a lot of the times these patients are kind of diagnostic challenges. They come in, you got a pinched nerve, you got to figure out, is it really coming from the neck or is their pain really coming from something else? On top of that, the analogy that I kind of use is that, if you take a car that's been driven for 5 years into the shop, right, it's working for the most part just fine. That mechanic can find something wrong with that car, right, and he can make recommendations as whether or not to fix it. But otherwise, the car's running fine, right? It's the same thing with a person. When you've lived 20 years, your spine, if you get an X-ray of the spine or MRI of the spine, it's going to show some damage, some deterioration, some aging. And that's just all part of the normal process. When you get to age 60, which is a lot of times the patient population that we're treating, 90% of those people are going to have MRI changes or X-ray changes that, could be considered in the right setting surgical, right? So you really have to be able to kind of tease that out. Is this just normal wear and tear, or does this actually correlate with what, this patient's actually experiencing. So again, clinic to me is very fascinating. Surgery, I kind of talked about it, when I'm talking about the anatomy, I mean, it's cool. And the nice thing is within spine surgery, the technology has really like just skyrocketed in the last 10, 15 years. And so by the time you guys would be coming in as spine surgeons, I can only imagine the type of technology that you guys would be able to play with to treat your patients. For instance, right here, here's a robot that I've been using a lot of at Cedars to kind of help put in screws into the spine. And so these are all things that are kind of happening right now. This is right here in kind of figure E, two small tubes that are being used to approach the spine to basically clean up some nerves around the spine, and then ultimately fuse the spine, put some screws in and fuse a segment of the spine. Before, you'd have to put this big incision in the midline, kind of fillet everything out, and that's obviously very painful. And so these are advancements that are happening right now that are just getting better and better. So by the time that you guys get out to becoming spine surgeons, if that's what you guys choose to be, there's just going to be so much more, and the future really is bright for spine surgery. This is just a video of a robot arm kind of moving around. I don't know. I mean, it doesn't look that cool, but it's pretty cool. Typical schedule for a surgeon really varies. If you're, without kind of getting into the weeds here, there's different employment models. So if you're employed by the hospital, they kind of tell you oftentimes what to do, and so they kind of set your schedule for you. If you're going into private practice like myself, where you kind of end up being your own boss, you really set your own schedule. And so really the schedule depends, but it's going to be some sort of, mix of OR days versus clinic days. And again, as far as, how late those days go, really are, one, dependent on the practice model that you're in, whether you're employed by a hospital or if you're private practice. And honestly, up to you as well. If you want to work super hard and for whatever reasons, then that's one thing. Or if you just kind of want to cruise and not work as hard or work as many long hours, then that's kind of up to you, I think, depending on, again, the employment model that you're in. On weekends, you're typically rounding, unless you have a kind of team to kind of cross cover you, you're rounding on your patients that might still be in-house. And then if you take call, then obviously that would add some additional workload to your schedule. I won't be taking any call. Just some pictures inside the OR. If you guys have never been inside the OR, that's me back there pretending to be important. This is a what we call a C-arm here. This is oftentimes what we use so it's basically an intraoperative X-ray, and it's what we use to this is we'll be operating on. This is what's called a bear hugger. Literally just warms the patient up during surgery. Up here is anesthesia. You can kind of see the tube going to the patient here. So currently he's being mechanically ventilated. He's asleep. And then down here is a screen for the X-ray. And then, depending on the OR, you may have some various monitors throughout to kind of help showcase some stuff. Here's our robot arm. This is the kind of tech that operates the robot. This is a circulating nurse who kind of keeps things moving, fluid within the OR as we progress with the case. And right now she's about to clean off the skin with some antiseptic solution to prevent infection. Before you operate, you got to get those hands clean. So this is what we're doing here. You can do that two ways nowadays. You can use a traditional scrub and scrub your hands for at least kind of 2 minutes or so. Scrub all the way up to the elbow and then rinse that off. Or there's now a antiseptic gel which you can use as well. which I personally don't like very much, but so I do a traditional scrub, but up to you guys. I'm wearing some loops, right? So some glasses that will help me to see a little bit better and a little more closely during surgery. And then I have a headlamp on here because oftentimes you're working through small holes and can get pretty dark in there. So that's why we got a headlamp. That's my one of my former bosses at USC. He's a neurosurgeon. So inside the OR, just kind of showing you again some cool tools that we use. Again, robot drill being held by the robot and literally drilling into the spine here. So again, that's pretty cool. Get to use microscopes. So loops allow you to see to a certain magnification. The microscope really allows for even more significant magnification, and it's very kind of clear and a very clear and vivid image. And when, in particular, if you're working around the nerves or working in a small hole or something like that, a microscope can really be helpful to make sure that you're doing the right thing. Right here, I'm just kind of, this is the only picture I had of us setting up for computer navigation. So that's another way that we can operate in surgery is actually using computer navigation to kind of figure out where we are. And nowadays they've got like virtual kind of almost like virtual reality glasses to kind of help you see where you're at in the spine. And there's just a lot of like really cool technology coming out in spine. And again, it to me, if you're going to choose a specialty, you want to choose a specialty that when you see yourself in that same specialty 10, 15 years from now, that you feel like it's going to be one that is going to keep you excited, that it's going to continue to challenge you, right? You don't ever want to have to get out of bed and be like, oh man, like, still doing this, you know? For me, I want to be doing something that's constantly going to be challenging, that is going to get me out of bed every morning. And I think that's, for me, that's spine surgery. So just something to think about as you guys kind of figure out, even within medicine, which disciplines you guys want to go into. This is just showing you a quick video of, you know, the skills that it takes to work within the spine. And what I mean by that is like literally you're working through a 22 millimeter tube there to, you know, drill bone and drill around the spine to ultimately kind of clear the nerves off for various reasons. But anyway, just to kind of show you that that's the type of, you know, finesse that you may need. I think we're going to run out of time here. I was just kind of looking at the timer here. Do you want to restart the meeting?
Yeah, we can like restart the meeting right now if you want.
Yeah, let's just do that just so
Okay.
Yeah, sorry about that.
No worries. No worries. I get it. Zoom started to get cheap on us. They used to allow for endless length of meetings, and now they don't.
Yeah, I didn't know that. I didn't use Zoom before this whole quarantine thing happened.
Yeah, I think most people did not, but yeah, and then they started charging to allow you to if you want like full length meetings, you got to pay. So so yeah, I was kind of being a little cheeky there, but you know, this is really just to show you the types of, you know, different types of surgeries that we do. So like with big deformity surgeries, it takes a lot of almost brute strength and you know, a lot of kind of endurance to kind of get through those big surgeries, because it's a lot of hardware, it's a lot of, you know, moving the spine around, and it's honestly kind of physically taxing. But the other thing that I really like about spine is not only do you have that aspect of spine, but then you also have this aspect where you have to have a lot of finesse in order to perform some of these surgeries well. And again, you can kind of see here, you know, kind of case in point here, I'm down on the spine and I'm drilling around, basically the nerves of the spine so that, we can kind of give them more space. One of the things that happens with arthritis of the spine is that, I should have put a picture of, here's a little bit of I want to give you guys a little bit of clinical information here too, just so this makes sense. This is not endorsed by Mayo Clinic, so maybe I shouldn't use that. Here, I'll use this one. Here we go. I just want to show you just a little bit of the anatomy here. So what I'm talking about here is, so what we're looking at is a spinal, what we call a spinal segment. So you've got two vertebrae, which are the bones of the spine. And then you have what's called an intervening intervertebral disc. And so again, as I kind of mentioned earlier, this disc acts as a shock absorber. And you guys may have heard of arthritis in like the hips or knees or the shoulders. In the hips or knees, basically, you've got like the hip, you've got like a ball and socket, right? And on the ends of the bone, you have this kind of smooth cartilage. And once that wears out, that's what we call arthritis. And the reason why that's a problem is that when that smooth cartilage wears out, the bone underneath is like sandpaper. And so you've got sandpaper kind of grinding on sandpaper, and that causes pain. And so the body will build up bone spurs and all these different things to kind of protect against that pain and really to kind of stiffen that joint so it doesn't move. And that, again, that's what we call arthritis in like the hips and in the knees and the joints of the body. In the spine, the equivalent of that is when the disc wears out. So again, the disc is kind of like a shock absorber. It's full of this gelatinous material, which we call the nucleus pulposus, and it's about 80 to 90% water. And so what ends up happening in arthritis is that nucleus pulposus actually dries out. This happens with aging, and genetics can play a role. You're a smoker, diabetic, things like this can accelerate this process. But what ends up happening is, you can kind of see these percentages here, right? What this is showing is that when you look at the spine, particularly in the low back, the front of the spine takes about 70% of the load of the body, right? So the purpose of the spine really is two things, is to kind of keep us nice and straight and to support the weight of the body. And then also it protects the nerves that allow us, basically the electrical wiring of our body too. But so from a kind of structural standpoint, the front of the spine takes about 70 to 80% of the load. And you can see that the disc, again, is, because it's in the front, it's kind of taking part in that function of the spine. If the disc wears out, what ends up happening is that these little guys in the back have to work harder. And they're almost like mini knee joints. We have these things called facet joints back here. And we have a bunch of ligaments and stuff too. But what ends up happening is, because they have to take more load than they're used to, as the spine becomes arthritic, they start to get bigger. And we call that hypertrophy. So you start seeing what's called facet hypertrophy and ligamentum hypertrophy. And it's much like, when you go to the gym and you work your muscles out, with weights, that's kind of what, at least guys are trying to do is, build some big muscles. But that's essentially what happens to these structures in the back once the front structures wear out, is that they start to get bigger. Now the problem with that is, once they start building up bone spurs and start getting bigger and thick, really there's only so much space for the nerves. So this little hole here is where a nerve would come through. And so if these guys are getting really thick and big and they're starting to encroach on these nerves, the nerves can get pinched. And that's what can cause like nerve pain and weakness and things like that. And so kind of going back to, what we're talking about here, that's basically what we're doing here, is that we're trying to remove some of that thickened bone and ligament so that that nerve can breathe. So that's why I'm drilling and so on and so forth here. And so you can imagine, again, kind of in contrast to like a big deformity surgery where you're just trying to straighten out the bones, when you're trying to take pressure off nerves, these very delicate structures, it takes a lot of finesse. And so again, that's what I really love about spine, is that you kind of have to, you kind of have to be able to do it all. You have to have that finesse, you have to have that hand-eye coordination, but at the same time, it does take some kind of, brute strength and muscle at times too, if you do deformity. Not everybody does deformity surgery. So any case, that's kind of what I was trying to showcase for you guys. So that's all I really got for you. Hopefully that was enjoyable. And then if you guys have any questions, I'm happy to answer any questions you guys have.
Hello, I'm Kevin. Thanks for the talk, by the way. But first question I had was, you mentioned in the beginning how orthopedics in general is just a very competitive residency to get into. So do you have any recommendations as to once we get into med school, how to make ourselves a better applicant?
Yeah, no, it's a great question. I think, it's kind of common sense stuff, right? Like, obviously get good grades, there's board scores that matter. So, common things, your first 2 years are typically like, didactic grades, and then you've got clinical years. So you want to make sure that you perform well on all fronts there, if you can. Board scores obviously are important. Now, USMLE, I think, is going to pass fail. And so I think from an orthopedic standpoint and for more competitive specialties in general, they're going to start placing a little bit more emphasis on step 2, which is kind of the clinical portion of step 1. Step 1 used to be like, so let me back up. The USMLE is basically a board exam, much like it's like the MCAT, right? But it's in 3 steps. You take the first step after like your first 2 years of medical school, and it basically, that's the step that's become pass fail, and it used to be kind of more like basic science stuff that you were being tested on. Step 2 happens after your clinical year, so as early as after your 3rd year, or you can even take it in your 4th year. I think with the changes, more people are going to be forced to have to take it at the end of the 3rd year, because I think more competitive specialties are going to start relying on that number there to, kind of see how strong of an applicant you are. And so I think that, you obviously want to pass step 1, but I think step 2 is going to start gaining a little bit more importance. Whereas in the past, step 1 used to be kind of the way to make yourself stand out from a score standpoint. And that's actually been shown in the literature. It was actually just published this last summer, a study that kind of basically polled a bunch of the program directors of orthopedic programs, and they basically said, yes, we're going to start placing more emphasis on step 2 since step 1 is now pass fail. So scores, important. Research, unfortunately, is becoming more and more important, whether you like it or not. If you love research, great. I personally think research is important for everybody to do, whether you end up doing it, when you're in practice. I think it's something that you should do, just to kind of understand, how to interpret research, because I think there's a lot of bad research out there. You got guys like me putting research out there, you probably don't want to trust that, right? But that's part of the game. You just have to do it in order to kind of pad the CV. And unfortunately, from a medical school standpoint, if you're trying to get into a competitive residency, that's the stuff that they're looking for. So get involved in research. Doesn't necessarily have to be orthopedic related or whatever subspecialty you're looking at. If it is, it helps, but it doesn't have to be. I think more importantly, what people are looking at is that you understand how to take a research project from start to finish, and that you can do that. I think that's the most important thing. Beyond that, letters of recommendation. So, this is where actually going to an institution that is affiliated with a big academic center can help, because if you've got strong connections within, let's say the orthopedic community, because you were at an institution that had very, well-known orthopedic surgeons at the academic center, then that can be very helpful if they're on your side. They can make phone calls, write letters of recommendation for you. And that, believe it or not, is very helpful. Finally, it's the kind of combination of the interview and the away rotation. So an away rotation is basically, for those of you guys that don't know, it's pretty, I would say it's almost mandatory for like the competitive specialties. You go to these institutions that you're interested in you know, ultimately becoming a resident in, and you rotate at those programs. And it's essentially like a 1 month interview. You know, you work within that system, you get to know that system very well, the people within that program, and it's basically a month-long interview. And I think more and more, because of how competitive, you know, at least, you know, in my experience with orthopedic residents or applicants are getting, it really boils down to oftentimes the kind of personality aspect of those individuals that you just can't get from paper, and even in an interview, right? And so that's where the audition rotation becomes so important. And in particular, because orthopedic programs are smaller, in general, you know, you're talking somewhere between 2 and, you know, maybe max like 12, you know, 16 individuals at the largest institutions, but on average, probably 4 to 6. You can't really afford to have somebody who's going to be a problem for you, who's not going to get along with others and stuff like that. So I think more and more they're placing emphasis on that kind of in-person, you know, if you have somebody vouching for you from another institution that knows people at, you know, the various institutions that you're trying to get into, you know, that's almost just as good, right? It's like, if I know you, I've worked with you for 2 years, and then you're trying to go to some program where my buddy is, you know, working, you know, is an attending there, I can be like, hey, you know, Kevin's a good guy. I've worked with him for 2 years. He's got no personality issues. He's a hard worker. And then it's almost like, we don't really need, if I'm the guy over there, I don't really need to see you rotate with us, because I believe me at the other institution. Does that make sense? So you have somebody vouching for you and your performance at another institution. So I don't know if that answers your question, but those are kind of the most important things. And you know, in fact, if you go to it's called JAAOS. I'd write this down. And just PubMed, there's like an article published over the summer on like, it's like program director, I don't know, the selection process for residents or something like that. If you look into that, it actually kind of breaks it down, like what the priorities are, what they're looking at, things like that. And in fact, I think I want to say it's the NRMP website, they've got this a lot for like pretty much every single program. So when you guys get to this stage, they've literally pulled a lot of the, you know, program residency directors at pretty much in like every specialty. And then every 2 years they come out and they publish this data on like what the program directors are looking for, you know, what the average scores are and things like that. And so it's all kind of to some degree specialty specific. And so you guys can go to the NRMP website and look this stuff up.
Hi, I don't know if you can hear me. I have a question. So I'm actually from the UK, I'm not from the States, but I'm interested in orthopedics in the States. Did you have many international graduates on your residency program? And do you have any advice to stand out more? Because like you said, the USMLE is now pass fail, so they can't distinguish between us as much.
Yeah, I mean, I personally did not have any international, formally international students or residents at the program that I was at, but I did run across a few along the way. And, you know, I can tell you what they did was, you know, obviously, you know, grades and scores. Again, step 2, I think is going to be very important for you. I don't know if you have to take step 3 too. I don't know how it works. But you know, try to do the best you can from that standpoint. What I've seen a lot of people do, in addition to the audition rotations, so in addition to trying to come and you know, try to rotate at these institutions that people are trying to get into, is do a research year. So for instance, when I was you know, rotated at Mayo Clinic in Rochester as a medical student, and then I went back as a 5th year because I was part of that same system to you know, just basically do some extra training up there. And there are a lot of international students there, and that's exactly what they're doing. They come, they do a research year, get to know, some very well-known people within that, specialty that they're interested in, publish within that specialty, and the combination of the two kind of helps them in the door, right? And I think, another kind of strategic thing to do is that I would look at programs that traditionally have taken international students. And so you can actually go to a lot of these, program websites and look at their current roster or even like their alumni and see if they have had accepted previously international students. Because, unfortunately, there's still, because how competitive orthopedics is, or really, this can be applied to any competitive specialty like plastic surgery, dermatology, ENT, urology. When you start looking at some of these, very competitive specialties and you start seeing it from their perspective, right? When you've got like literally my program this past year, I was talking to my program director, we take two residents every year. They had 800 applications. And I mean, these are not like everybody's applying. These are people that are interested in ortho that are very likely, the majority of them are going to be very competitive on paper. So when you have that many people that are applying that look awesome on paper, right? Like you have to see it from their standpoint. They're going to start selecting on things that, just kind of make sense off the top of their head, like reputation of program, board scores, grades, letters of recommendation. And then more importantly, do they know that person on some scale? Like, did somebody call on their behalf, or did they rotate at, your institution and things like that? And so again, that's where I think, getting that face-to-face time, whether through a research year or something like that, I think will definitely be the way to go for you. And it's not impossible. I've seen it. I've seen plenty of international students in orthopedics. It's obviously less than a US grad, but they're there if you're willing to kind of go down those routes. I hope that helps.
It does, thank you.
Anything else? Don't be shy. Don't be nervous.
I had another question. So I've heard a lot about MD versus DO and the differences. I was wondering if you can just highlight some of the differences, the benefits, the bad things, whatever or not.
Yeah. I mean, it's really kind of a loaded question, and I think nobody really ever gives a straight answer. I think the kind of de facto answer is that really at the end of the day, there's no difference. But as far as the schooling goes, the DO, we do more, we obviously do the OMM, the osteopathic manipulative medicine. And traditionally you've kind of taken this holistic approach to the patient care. Now, just because you learn that as a DO doesn't mean that as an MD, like, oh shoot, like you're not a holistic practitioner, right? Like you can easily adopt that philosophy. You can easily go learn some manipulation if you want. And so I think at the end of the day, it really boils down to, in terms of what you want out of your training and the type of doctor you're going to be, it really depends on you and kind of what your interests are. Just because you go to a DO school doesn't necessarily mean you're going to do, OMM, or you're going to be more of a holistic practitioner, right? Like I'm not doing any OMM. I'm a surgeon. But that being said, like my background in general and who I am makes me a little bit more, I guess, holistic in my treatment in patients. But I don't think that necessarily has anything to do with the fact that, I was a DO necessarily. It's just my philosophy. And I started out in chiropractic. I was a personal trainer. And so I do believe that there are other modalities that can be helpful for patients. So I guess what I'm trying to say is that just because you learn those things in DO school doesn't necessarily mean that, as an MD, you can't do that. I think on the flip side, on the MD side, they, in general, you typically, programs are typically more affiliated with larger academic centers. And then as a result of that, you have more research kind of capacity or opportunities, which I think is very helpful. I think, again, at the end of the day, I think it's important, even if you hate research and you never want to do it the rest of your life, I think it's important to actually try to get involved in research, not only because it's almost like required nowadays for like the competitive specialties and if you want your application to be competitive, but from a patient care standpoint, there's so much crappy research out there that if you don't know how to decipher between what's good and what's bad, you may be applying the worst practices from new research to your patient care. And you don't want that. You wouldn't want that for your family members. You wouldn't want that for your friends. And unfortunately, that's just the landscape that we're in with the research nowadays, because there's just a lot of crap research out there. And so I think from an MD side, you kind of have a little bit more opportunity to learn those things or get involved in research. But that's not to say that if you're a DO, you can't do those things. But yes, the opportunities may be less. That being said, once you get into residency, depending on, what your goals are, most residency programs have, tons of opportunities for research. And so I did a lot of research during residency, and then even now during fellowship, I'm doing a lot. So even as a DO, I'm not trying to float my boat here, but, I'm probably more well-published than the average, MD person in my shoes. And so again, it doesn't matter. It's really up to you to kind of make that difference for yourself. Now, as far as like opportunities go, I think that this is the thing that really isn't talked about as much, even though it's true. I can tell you as a DO going the MD orthopedic route, I was a little bit of a trailblazer. I mean, there was people that had done it before me, but it's very rare because, again, it kind of goes back to that thing. When you have 800 applicants and they all look awesome and they all have the same scores, who are you going to go with? Are you going to go with the guy from Harvard, or are you going to go with the guy from, the state school or the, community college? And I'm not comparing DO to community college, but you kind of get the point. So, that was certainly something that you saw. There was a bias, particularly in these kind of old school surgeons against DOs. And I think in the competitive specialties, that's going to be the case for, some time. Now, that being said, there are formerly DO residencies that have all kind of merged together under this one umbrella of the ACGME. And so in that regard, I think it may be a little bit just easier to get a residency in general, but it's still going to be hard. And the traditionally MD programs are still going to be, hard to crack as a DO if you're going for very competitive specialties, or, within more DO friendly specialties, the most competitive programs. And it's just, again, it just goes back to the fact that when you've got this huge mass of like incredible applicants, right? Like, unless there's something about you from a personality standpoint or something that just really makes you stand out, what's going to make them take your paper, you on paper over somebody else that maybe looks better on paper? Beyond that, as far as like getting a job or something like that, I don't think it really matters. I think once you're a surgeon or you're a doctor, really at the end of the day, it's kind of who you are as a person, and then, to some degree, kind of where you trained, but in residency and fellowship. Now, the caveat to that is if you're trying to go into academics and your goal is to be like a professor at, I don't know, like Johns Hopkins or something like that. I can tell you, again, within orthopedics, that would probably be hard for me to do if that was my goal, just because there still is some of that bias. And I can tell you there are some institutions that literally only look at MD applicants for faculty positions, even though I've trained at good institutions, right? Like I trained at Mayo Clinic in Arizona. I trained at USC, all big academic centers. I'm at Cedars now. But I can tell you, even based on that, unless I had maybe some people like really just go fight for me to work at these places, there is still some of that bias at the academic level. So, that being said, I think that things are getting better, but I wouldn't want to give you the wrong picture. There still is some bias against DOs. And my advice always to medical students is, just go to the best program that makes the most sense for you, you know, just get in, first of all, get into medical school, because that in itself is a huge hurdle. So get in, and then, you know, then just work your butt off, you know, do the best you can, be a good person, you know, stay humble, and, you know, things are going to work out. Right. Yeah. If you can go to a better, you know, more well-regarded medical school, you know, you're going to start up here versus, you know, maybe down here having to work your way up. But that's not to say that the guy or gal that starts here is going to have, you know, is guaranteed to, you know, get into orthopedics or, you know, get into the best places. They still have to work hard too. And it's still very competitive for them, but it does give them a little bit of an edge up to begin with. I hope that answers your question.
No, it did. Thank you.
Yeah.
That was helpful.
Anything else, guys?
There is one question in the chat, if you don't mind just looking at it.
Yeah. Oh, biggest obstacle. You know, I think it's really just been overcoming, you know, the hole that I dug myself into, right? So I told you guys I started with like I think I told you guys I started with like a 1.8 GPA after my first 4 years of undergrad. You know, to dig myself out of that hole was tough. But again, I mean, for those of you who think that, you know, you can't turn it around and it's too late for you, you know, I'm kind of case in point, like you can do it, you know, just put your mind to it. And I think the most important thing for me, the thing that I really learned, unfortunately, maybe a little slower than I should have, was that there's going to be a lot of naysayers along the way that will tell you that you can't do something just because, you know, statistically, maybe it hasn't been done. But at the end of the day, only you know yourself. And so if that's what you want and you feel like you can do it, just go for it. And that's what I did. And, you know, I was lucky enough to kind of, you know, get to where I'm at now. And so I think that was the biggest hurdle, was just overcoming that, and then overcoming all the naysayers that told me that, you know, oh man, like you can't do it because, you know, your grades are so crappy, or, you know, even like getting into orthopedics as a DO, you know, I was only DO my year to get into an traditionally MD orthopedic program. And I can't tell you the number of people that told me that I couldn't do that. But I kept going for it, and it paid off. So again, only you know what you're capable of. Kind of don't listen to the naysayers. And, you know, I would say always get a second opinion, third, fourth opinion. So, you know, even from people that you feel are like the you know, maybe the experts, right? Like they still only have one perspective. So like, I'm telling you all this stuff, and I would encourage you to still go out and talk to other people about the same things that we've talked about, and have a better idea, a more global perspective of some of the same topics that we're talking about. I think those are the kind of lessons that I've learned from the obstacles of kind of digging myself out of that hole. As far as what did I rely on to stay motivated and productive, you know, I think that this is where kind of setting goals helps. You know, people always talk about this, and I always knew about it, but I didn't really understand the power of it. But, you know, I wrote down my goal as soon as I realized, like, okay, I want to go to medical school. I want to be an orthopedic surgeon. I want to go spine. In order to get there, I got to get, you know, 4-point GPA from here on out. I need to get, you know, X score on the USMLE. Like I literally wrote these things down and put them somewhere where I could see them, you know, on a day-to-day basis, and just kind of focusing on being able to see those things like very frequently, I think kind of kept me on track. You know, it's not like you write something down, you put it in front of you, and then magically, like, you know, you're going to get there, but at least kind of in your head keeps you focused on what those steps are for you. And so if you're like, you know, you're tempted to, like, you know, take 3 days off and, you know, go to Mexico with your buddies, you know, instead of, you know, studying for a test, you look at the board and you're like, oh man, like, you know, I have that test coming up. I have to do it because, you know, I have to study for that. You know, I have to get this. Otherwise, you know, I can't get to the next step. And so it kind of helps keep you focused and grounded. creating goals for yourself. And then, you know, at least for me, that was helpful because I went from somebody who didn't study very much, and to ultimately I needed to become somebody who did. And so then once I got in the habit of doing these things, and you know, got my, you know, efficiency down with studying and getting work done and things like that, then it just became a part of who I was. And so nowadays, like, if I'm not doing something productive, like I feel like, I don't know, I just get all antsy, you know, because it's just become a part of who I am. And so I think kind of once, you know, in order to get to that stage, you may have to set some goals and things like that. And I still set goals, but I don't, you know, I don't put them in places I can see. I just kind of have them in the back of my mind now, because now I'm kind of programmed to be the way that I am. But those are kind of some of the things that I did. And then as far as like staying productive, I think every minute counts. Particularly as you guys get into, you know, right now you guys feel like you may not have a lot of time and so on and so forth, but I can tell you that you're gonna have less and less time at each stage of your career. You're gonna get to medical school, there's gonna be less time for you, and you just have to find ways to make the most of the time that you have there, and you'll figure it out. But I guess what I'm trying to say is that each step along the way, your time becomes more and more valuable. And so like, even like getting on Instagram for like 30 minutes, like during those 30 minutes, like, you know, as a resident, I could have wrote, you know, 10 notes, you know, and not had to do that later on, or, you know, something like that. I could have, you know, maybe worked on a part of a research project during those 30 minutes. And so I would just encourage you guys, if you guys are finding that you don't have enough time in the day, to really kind of take a look back at what you're actually doing throughout the day, you know, over a course of a week, and seeing where you can kind of make up extra time, because you may be doing things that you're not even realizing, like looking at Instagram for 45 minutes, you know, getting on and watching sports for, you know, watching football on Sunday for 5 hours, which is all fine. You want to be able to, you know, still have a good time. But at the same time, if you're really scrounging for time and you're looking for ways to be more productive, you know, it's got to come from somewhere, right? So either you become more efficient in the things that you do, or you try to find, you know, pockets of time that you may not be realizing that you're wasting. Does that answer your question, Faith? I'm gonna take it yes. I'm gonna take it yes. Anything else, guys? Looks like we're about to end here again, so. Absolutely. Well, hey guys, I appreciate you hanging out with me on a Sunday. If you guys have any questions about anything, just shoot me a message on Instagram. Seriously, about anything at all.
Thank you so much for coming.
Yeah, of course. Sorry I was late.
No, it's okay. Well, your talk was very like motivational. I feel like I should be doing something more. Yeah, okay. Thank you.
All right. I'll see you guys.
Thank you.